As I mentioned earlier this morning, we were supposed to have Dr. Larissa Geskin from Columbia join us, but she got sick. So she's at home. She is devastated because she loves interacting with all the patients. So I'm sure we'll be doing something with her in the future. But it is delightful to have Dr. Jennifer DeSimone, who some of you met yesterday, who has graciously changed her home schedule to join us this morning for the Q&A. Dr. DeSimone is a specialty cutaneous lymphoma dermatology oncologist here in the Virginia area, and many of you know Dr. DeSimone, and we're also joined by Dr. Aarthi Shenoy, who is here as well in the DC area as a hematology oncologist working in the cutaneous lymphoma space with Dr. Stefan Shika, who you heard yesterday. So it's really wonderful to have you both join us, and y'all can just come on down here. It's going to be casual. I'll do mic running for anybody that has questions, so raise your hand high, and Autumn will be bringing in our questions from our live audience. Thank you both for joining us on a Sunday morning, and again, it's really a wonderful to have you. And so who wants to be the brave person to have? See, look, we have people already ready to go.
Hey, good morning. Thank you. I'm really curious. I haven't been able to find out any information as to how immunocompromised our community might be, and maybe how did we fare during this whole COVID thing?
I have big shoes to fill with Dr. Geskin not being here, and I apologize that she's sick, but I will do my best. I think this is an excellent question and one that I've encountered very frequently in clinic. When we think about cutaneous T-cell lymphoma and any degree of immunosuppression that it might cause, it's really important to note that people who have early stage disease are immunocompetent. You know, you're not immunosuppressed. The people that are immunosuppressed are the people with very advanced CTCL, with a lot of blood-borne disease or nodal disease. Those are the people whose systemic immunity is impacted by a large percentage of dysfunctional immune cells versus patients who really only have skin disease. So that's an important thing to note. But then when you talk about various therapies that patients might be on for the treatment of their disease, some of those drugs can impart some further immunosuppression, for instance, methotrexate at moderate to higher doses. Some of the more traditional systemic chemotherapy agents can cause reduction in your white blood cell count. So that's when we start to be concerned about maybe patients being more susceptible to any form of infectious disease. But on the whole, the vast majority of patients are not dealing with an immunocompromised state as part of their CTCL.
Okay, I'll just add to that and say that a lot of, as physicians, we did get a lot of direction during the COVID pandemic. For example, we got a lot of direction from the FDA regarding who should get Evusheld, which is the preemptive kind of monoclonal, and who should get a more accelerated vaccine strategy. I think one of the biggest kind of players in that was the CLL Society, which we use a lot of similar medications. So we were able to get some direction on how to kind of bump up any kind of preemptive treatment or preemptive kind of vaccine therapy we could do.
I'm sorry, which is the CLL? I'm not familiar with that.
So CLL is a totally different leukemia, but it also uses similar drugs that we use for advanced stage disease, and they were able to give us some direction too, as well as the NIH and the CDC.
From the online audience, what impact does a continuous glucose monitor sensor have with CTCL and skin treatment? They had some other in there, but to paraphrase, they're having difficulty moisturizing the skin in the area.
Anyone who's got cutaneous T-cell lymphoma with primary skin involvement is going to have a defective skin barrier. And so if you're looking at instrumentation on the skin, that can create a problem there. I encountered in fellowship a patient who had an estradiol patch that they were wearing, so another one of these kind of percutaneous type medications, and that had exacerbated an underlying patch of CTCL. So if you're wearing a cutaneous glucose monitor, you want to try to place that in a location where you do not have active disease, if you have that luxury. And if you're experiencing additional skin sensitivity or skin breakdown, again, because you've probably got some more global underlying barrier dysfunction in the skin, then functioning or focusing on really strong and consistent use of emollients is going to be the best way to go. For instance, you want to take something thick like Aquaphor and have that applied liberally on the skin at the contact point of any percutaneous medications or any devices that you have to use through the skin.
So I have more if I just don't want to monopolize. So this is a question that we see quite often in our Q&A is there a special diet to follow? I know it's a tough one.
So we were just talking earlier just about wellness in general, and I think that when we, anybody that has a chronic disease, specifically a chronic lymphoma like this, really needs to just work on wellness in their diet. So eating a very well-rounded diet, I think, is important. I think, our bodies are a temple, so anything you can do to nourish your body in the appropriate way is important. I don't think that there's any specific types of supplements or anything like that are needed, aside from, making sure your vitamin D is checked. As we know, patients can have vitamin D deficiency. But other than that, I would just say a well-rounded, keep that food pyramid, intact.
May add one point, then this is a very general comment, but our immune system is tasked with tumor surveillance, right? Preventing and controlling any sort of malignancy. And when we bombard our bodies with a lot of chemical additives, preservatives, things like that are pro-inflammatory, the way that I interpret that is that it basically distracts your immune system from being able to focus on its maximum functioning in tumor surveillance. So avoidance of heavily processed foods that can live in your pantry for 10 years without going bad, those types of things are hard for your body to deal with, and I believe those things can distract your immune system from working at its maximum capacity in the realm of tumor surveillance.
When the audience can't hear you. So this is how I get my exercise, guys. Remember.
I have a question, but as a follow-up to the question about diet, what about sugar? I've heard that sugar in particular can be problematic. But my question also has to do with immunizations. I know, like with the new shingles vaccine, that's I think a dead virus, whereas the previous shingles vaccine, it was a live virus that we shouldn't have taken. So I was curious about that and other vaccinations.
So sugar, I'll just say one thing about that is, again, I think keeping a balanced diet. I will say, though, that if you're a diabetic, keeping your sugar as controlled as possible is needed for the immune system to work optimally. We know patients with diabetes who have higher sugars just have worse, as Dr. DeSimone was saying, immune surveillance. Getting to your question about vaccines, I think, again, that depends on your stage of disease. Clearly, if you're immune suppressed, you do not want to take a live vaccine. I would say most of our vaccines are actually dead, except for some types of polio. The Shingrix vaccine we've been giving liberally to all of our patients. It's actually better to get these vaccines and not get shingles than to not. So the ones we tend to recommend are the pneumonia vaccines, usually the Prevnar, and then the pneumonia vaccine, the Shingrix, tetanus. I think those are the big ones. Flu, yeah, absolutely flu, yeah.
I'll take one while you work your way over. Does having to wait for many years to be properly diagnosed put a person at higher risk for more serious outbreaks in the future? specific patient was diagnosed with MF after 10 years, and they're just concerned that it could get worse in the future because it wasn't properly treated for so long.
So on average, it takes 7 years for people to be diagnosed, and that's certainly a problem. And I think that it is explained best by this disease being slow in its maturity or its evolution. And so initially, patients present with a physical exam that's not clinically diagnostic for CTCL. And then even if you biopsy these patients multiple times early in disease, often those biopsies are lacking in the critical diagnostic features required to make a concrete diagnosis. And so that, I believe, is what takes so long for people to get diagnosed. But luckily, I brought this up yesterday in my session. It's kind of discouraging in some ways, but encouraging in other ways. There was a large study following patients over 30 years, and the question of the study was, does the introduction of therapy for early stage patients prevent them from advancing to higher stages over their lifetime? And the short answer is no, it does not. So I don't feel that this person who was diagnosed 10 years after the emergence of their symptoms has missed the opportunity to utilize therapy to control their lifetime experience with this disease. Unfortunately, some people have disease that is simply biologically more aggressive and destined to progress to higher stages, and they may have inherently poor tumor surveillance or kind of an inept immune control of the problem in the first place that also allows them to progress to higher stages. And starting phototherapy or starting topical treatments that are indicated for early stage disease does not seem to prevent patients from moving on to systemic stages of disease. So it's somewhat reassuring for this specific question, but also discouraging in the global picture, because you want to think that we have some opportunity to prevent a worse outcome, but at this point it doesn't appear that we have good data to support that notion.
One thing, piggybacking to what Dr. DeSimone said, I think it's very important, this 7 years and multiple biopsies sometimes to get your diagnosis. I think that let's just be honest, that's not great for a patient to go through that and not know what their disease is. But I think the other part of that is a lot of times when patients come to see us, they've lost confidence in their doctor because they have had 2 or 3 biopsies and they did not get their diagnosis. And I think this concept of it's just sometimes that biopsy is not going to be diagnostic is an important one, because I think it's important for you all to have confidence in your doctors, and that in and of itself may not be a good reason not to.
I agree. I think that there's a lot of justified frustration on the part of patients who received a diagnosis many years after their symptom onset, but practically speaking, you have to have certain diagnostic features, both clinically and histopathologically, to confidently assign someone a cancer diagnosis, and sometimes that just takes a while for that disease to evolve and mature, and it's not unusual for that to be the process, and it's most commonly not due to ineptitude on the part of the practitioner, but more so due to this slow evolving pattern of the disease in general.
It's hard to watch the TV news these days without seeing multiple commercials for drugs for skin diseases. None of these drugs are cheap, that's why they run commercials for them. But they're things like Skyrizi, Tremfya, there's a new one called Sotyktu or something like that, Otezla, Stelara, Humira. I've often wondered whether any of these kinds of medicines either have been looked at for our diseases, or whether the kind of trend they represent might be used to treat our diseases.
Great question. All of those medications that you mentioned are indicated for psoriasis, and they act by specifically inhibiting certain interleukins, we call them, which are pro-inflammatory, naturally occurring chemicals. And they are very precise. For instance, some of them will inhibit interleukin 17, others will inhibit interleukin 23. And they're very effective in controlling psoriasis, which is not a malignancy, but rather a pro-inflammatory condition. However, the pathophysiology of psoriasis is quite different than the pathophysiology of mycosis fungoides or CTCL. And so those very precise little barriers that you might put in the inflammatory tree are highly unlikely to have an impact in the tumor progression or the proliferation of atypical lymphocytes, unfortunately. So just knowing that while there are many questions about the etiology and pathophysiology of CTCL, we do know some things molecularly, and we do understand some pathways, and those psoriatic pathways do not correlate with the CTCL pathways, and therefore, unfortunately, the drugs that are effective in psoriasis are unlikely to have an impact in CTCL. I know.
Up with it's difficult to watch TV.
How common is it for people that have CTCL to also have other conditions like eczema? Because, it took a long time to get a diagnosis for mycosis fungoides. And then I was getting UVB, and I was complaining last winter that, okay, every winter this stuff gets worse, blah, blah, blah. And I saw the doctor, and he says, well, you also have eczema. And I thought, wow, I'm glad they didn't biopsy that instead of the wrong, because that could have delayed it even further. So I'm just wondering, is it something that often tracks with some of the skin involvement?
It certainly can, but having CTCL does not predispose you to other common benign skin conditions. But atopic dermatitis or nummular eczema is pretty common in the general population, and so you can see some overlap there. One thing that you don't typically see is the co-occurrence of psoriasis and cutaneous T-cell lymphoma, just because molecularly they're kind of in contradiction with one another. I do have 2 patients that have both, but the commonest thing that you're likely to encounter in a healthy patient in terms of skin disease is nummular eczema or adult type eczema. And so I think just because of the overall frequency of that, there can be some coexistence, but there's not a correlation. But you're right, thank goodness they didn't biopsy your eczema, because it would have delayed it further.
But being an oncologist, I will put in one plug, and that's what Dr. DeSimone was saying about the immune surveillance system. And the immune surveillance system in general being important for any adult cancers. And so doing all of the regular healthcare maintenance, not asking for, a whole body CT or anything like that, but making sure you keep up with your mammograms, your skin checks, your colonoscopy, your vaccines is so important, just to do everything you can to help that immune surveillance part of your body.
So I actually have 4, so we'll intersperse as we ask the people in the audience. How do I stop sebum flowing from my scalp? It happens at night when I put my head on the pillow. Yeah.
So I think this is unfortunately, one of those highly specific questions that is difficult for me to responsibly answer, because I don't know if it really is sebum or if the patient's just interpreting it as sebum. So I wish that I knew more and were able to see some photographs, but I don't want to give an inaccurate answer to that.
Okay, thank you. Anyone else in the audience before I keep? Oh, okay.
Hi, I'd like to talk about phototherapy for a second, and I'll try and be brief. Is there a new protocol? And I'll say why I'm asking this question. From August to January, I had UVB, and they increased it by 15% a day, and I was at max for a while. Took a break, went to Florida, it was very nice, came back, went to start over again, and of course I had to start from scratch, which is fine, I understand that. But then they started increasing it only 15 millijoules per session, and they told me it was because it was the new protocol. The new protocol, the citation on the paperwork they gave me was from 2016. That's 7 years ago. Is that the new protocol, or is there a newer protocol?
So I believe what they are referencing was the phototherapy guidelines in CTCL that were printed in the JAD in 2016.
Mm-hmm.
I'm not aware of any newer,
So
specific,
nothing newer.
universal practice guidelines beyond that. But I
Okay.
know that certain practices have to make adjustments based on really simple things like how recently they got new bulbs put in. or if they have a new machine.
Yeah,
You
they don't.
15 seconds when those bulbs are fresh is a totally different amount of energy than 15 seconds when those bulbs are 5 years old. And so sometimes they have to tweak things a little bit based on really simple details like that.
Yeah.
But in terms of newly published different guidelines, no, I'm not aware of that.
Okay.
I usually refer to the JAD ones from 2016.
Yeah, that's seems like that's the one that they referenced. Okay.
Right. So next question, do current drug therapies give longer incidence of remission from Sezary than earlier published studies indicate? And this person is from St. Paul, Minnesota.
So what we were mumbling about is that's a difficult question to answer, because it is a difficult question to answer. I think that about 6 to 8 years ago, we started to bring to market a totally different category of drugs that were effective and indicated in CTCL, and those are targeted therapies. A lot of the prognostic curves and the data regarding progression-free survival and how long you're likely to have a good response to your drug are outdated since the introduction and the practical implication of these drugs in the last specifically 5 years. So I'd like to be very optimistic and say, yes, I think that some of those older studies that looked at single agent drugs probably will give you an expected duration of benefit that, practically speaking, may be shorter than what we can get in practice. And that's because we have newer drugs, but it's also because we have a lot more experience combining these therapies now. And the combination of therapies can lead to synergy, which can lead to longer term duration of benefit. So I think the answer optimistically is yes, those numbers are outdated, I hope.
Thank you. Do we have anyone in the live audience that has a question? All right, I'll keep going. Is it normal for itching to increase with treatment even though lesions seem to be decreasing?
Absolutely. It depends on what type of treatment you're using, but I'll just give one example. In the setting of topical imiquimod, which is a topical immune modifying agent, the way that it works is that it stimulates a healthy immune response to the abnormal cells, so you get an influx of inflammatory cells. With that comes increased itching. So with many different therapies, I counsel patients at the outset of therapy that things might get a little worse before they get better, and that is normal and expected. But it should be relatively temporary. There should be an overall trend toward less pruritus or less itching with response to therapy.
All right, next one. Can you speak about vitamin D deficiency that you mentioned? I have had very low vitamin D and vitamin B12 and always wondered if it had anything to do with my CTCL mycosis fungoides.
So this topic of vitamin D is seen in multiple different lymphomas, and we've seen that in CTCL, only to say that we tend to check it and then replace it. But regarding, outcomes, I don't think there's clear data yet.
Good questions. Oh, okay, David. All right, let me see. I'm coming over. Because if you don't blow the thing, because if you don't use the mic, then the people at home can't hear you and hear the question. So, again, thank you for letting me get my exercise.
Thank you. Just another question as far as what we should be doing to stay on top of it. Are there any routine blood work that you recommend for people in relatively indolent stage?
So no, I think keeping just your regular physical and getting all of that regular blood work that your primary care doctor wants is important. I think we've run into this situation before when we do excessive blood work and CT scans in indolent disease. I tend to trust my exam and that of my dermatology partner first, rather than go to lab work or scans, because it's not infrequent that if you do a CT scan, you might find something, and that something might be very benign, but what you have to go through to figure that out is not benign. And so we try to do only what's indicated. So no, there's no regular blood work you need.
And just to add to that, as Dr. Shenoy said, we do what's indicated. And so what's indicated is in a patient with early stage disease, skin-limited disease, especially if it's quiet, it's relatively stable, the only thing that's indicated is a clinical exam at that point, which is a head-to-toe skin exam and palpation of the skin-draining lymph nodes, which include the lymph nodes in the face and neck, the underarms, and the groin. Those are the lymph nodes that are likely to become abnormal if you've got an issue in the skin first. Those lymph nodes will manifest pathology before the internal lymph nodes. And so in the setting of palpating those lymph nodes, if you find that a lymph node feels abnormal, then imaging is indicated. Then blood work might be indicated. But otherwise, the guidelines state that you do a clinical exam. If the skin looks stable, if the lymph nodes feel normal, there's no indication for PET CT or CT scan. There's no indication for peripheral blood flow cytometry or even just a complete blood count, because you're so unlikely to find anything relevant to the disease. The scenario wherein I do need to reorder basic staging labs or basic staging scans are if a patient presents with a new and worsening exam. So let's say someone's now much redder from head to toe and they're not responding to any therapy. In that situation, I need to consider that they may now have a problem in their peripheral circulation, tumors now developed in the peripheral bloodstream. And so in that setting, it is indicated by the guidelines to do peripheral blood flow cytometry and complete blood count and potentially LDH to assess if there's a correlation between this new worsening skin finding on exam and potentially more disease in the blood. And similarly, if I do my exam and I find that now there's new and abnormal changes in the lymph nodes, we have to follow that up with diagnostic imaging. But otherwise, no.
It's one of the most difficult conversations when people first come in with their diagnosis and they have indolent disease, because as you can imagine, you've just been given this cancer diagnosis, and we're saying, hurry up and watch and do a whole lot of nothing right now is what they're hearing. And this concept of we can do harm by doing excessive studies is something we often take a long time to explain to patients.
Dr. Shenoy is absolutely right. Let's say we do a PET CT when it's not indicated and they find, this happens not infrequently, you find some small nodule in the lung. It's probably old scar tissue from a bronchitis that you had in your 20s, but now we found that, and so now we're beholden to monitor that or further diagnose that, so then the patient has to get a biopsy in the lung, looking for what that is. Now they're subject to complications from that procedure. So that's what she's saying, is that sometimes intervention begets intervention to the detriment of the patient. So we have to follow the guidelines mandated indications for workup.
I have some more.
Oh, wait, we've got one in the audience here.
Sorry, didn't see.
Okay, thanks. I got two quick questions. The first one is specific to Targretin gel. Does that thin the skin? Is there any complications to longer-term use of that in larger areas of the body? Like, obviously, there's a lot of complications to steroid cream, long-term use, and thinning of the skin. And then the second part of my question is related to if you have a controlled, more advanced stage disease, is there any hope for being in a, I don't want to say the word remission, on just such a, is there any hope for being in a period of time where you could go under no treatment? And I've heard people say med breaks, take a med break for a while. Is there any benefit to giving your body a time off from these treatments versus staying on the treatments for the rest of your life?
With regard to topical Targretin, that's a topical retinoid. It's kind of like Retin-A, and it is very dissimilar to steroids because it does not create any atrophy or permanent thinning of the dermis. So when you think about the skin, there are many layers. The top layer is the stratum corneum, that's all the dead stuff. And then you've got the epidermis, that's the most superficial layer of skin, and then you've got the dermis. When you're using the Targretin, it can strip off the stratum corneum. That's okay, that's basically the dead layer anyway. But there should be no atrophy or thinning of either the epidermis or the dermis. Compare that with topical steroids. If those are misused in the extreme long term, those can cause some permanent skin thinning. But with topical Targretin, aside from the irritation that people frequently encounter, particularly with the 4 times per day advised dosing regimen, it's relatively safe.
So your question is for patients with more advanced disease who are on therapy, have a good response, and then what happens then? Do you stop treatment? Do you do something else? Do you continue on treatment? And I think when we think about that, we take it from twofold. Number one, what is the disease doing? How hard was it to get somebody to the point where their disease is well controlled? What has their past looked like? But then also, how are you doing? You know, how did you tolerate this therapy? Are you living your life the way you want to live it? Or are we just giving you a lot of treatment and you're not getting to do the things you want to do? We have to take all of that into account. One thing that we were talking about last night that we'd like to see in the field more is this concept of maintenance therapy. It feels to us that it would be good to get some form of therapy long term to keep the disease in check. What that looks like for each individual drug is still not clear. Do you give a lower dose with the same frequency? Do you space things out? But I think what trumps all of that is that if you are not tolerating a therapy and you need a break, I think that's the most important thing. And then after that, we do active surveillance closely.
I'll also just quickly say that this concept of maintenance therapy really needs to be further explored. So we know that this is a chronic disease, and particularly in the advanced stages, we know that it's likely to recur even after a great response to treatment if we discontinue all treatment. The way I explain it to my patients is if you have high blood pressure and we put you on blood pressure control medications and you achieve that beautiful blood pressure, does that mean you no longer have hypertension? No. If you go off your therapy, your pressure is going to go right back up. And with most cases of systemic disease, that's kind of an analogous scenario. But what we don't know, based on well-controlled studies or even long-term observational studies, we don't know what the frequency is of recurrence, and we don't know what the impact of potential maintenance drugs is on reducing that recurrence. We know that it's likely to recur, but we don't have any great data at this point to refer to guide us in our selection of drug, the dosing regimen of the drug, et cetera, to be able to confidently craft a maintenance therapy that we feel is going to be successful. So there's a lot of individualized, provider style in the mix. And we need to, as a group, collectively start to come up with concepts to design some controlled studies that can help us take a closer, more precise look at that. And so that's one of the things that a group of us were talking about last night.
And I'll say that this is not a novel concept. We do this in other blood cancers. I know when we think of cancer, we think of breast or colon cancer, but actually a lot of these indolent lymphomas that we have, in my world, we use maintenance therapy. So it's not a novel concept, and we definitely do it for other cancers.
Have any of your Sezary patients used low-dose campath treatment regimen, only 10 milligram and delivered subcutaneously instead of intravenously? Is that approach safer with less impact on immune system and yet also effective?
So there's been this debate about sub-Q versus IV versus how long you do it. I think you could argue pros and cons for both. I will say that no, I don't think one's less immunosuppressive than the other, and I think I think that it's important when you're at an institution to use it in the way that institution, the nurses, the physicians feel most comfortable using it, because that's when you're going to have the best outcome.
Okay, I'll go with the next one. Is there evidence that home phototherapy is better or not as helpful as the booths at hospitals?
There's no evidence of superiority with office-based phototherapy versus home-based phototherapy. The nuanced details are how comfortable and how proficient a patient is at titrating their treatments upward, it really depends on individual capacity to run their own phototherapy booth appropriately, but in terms of the quality of the device, that should be equivocal. So you should be getting just as good treatment at home as you are in the doctor's office, provided that you're competent and capable and comfortable following the instructions very carefully and that you adhere to the recommended dosing regimen.
All right, I'll go with the next. See any hands though? Anyone? With brentuximab, how quickly do you need to stop treatment to reverse neuropathy when it occurs? And how soon after reversal can you restart treatment?
So again, that's very patient dependent. It depends on what the neuropathy is, what we have different gradings, so how severe is it? And so depending on that, and if there's any other things going on, what's the baseline level of neuropathy? For example, patients with diabetes or something might have a baseline neuropathy. So I don't think we can answer that in a very standardized way. I think that is important to have that conversation with your physician, and your physician should be asking you about neuropathy every time they see you. There's various ways of doing it versus stopping altogether and seeing how people are doing versus a dose reduction. So that's not a very standardized algorithm.
I agree, and not everyone recovers from their neuropathy. About 10 to 20% of patients have irreversible neuropathy, so that's something that would need to be followed in the post-treatment timeframe to ensure that the patient has fully recovered before considering resuming, which would likely be done at a reduced dose and with very careful monitoring for recurrent symptoms.
I still have a few more, so I'll keep moving. Are there new drugs that are promising for advanced stage MF?
Yes, there are many. I think the most interesting ones coming out. Well, there are many interesting ones, but I think the class of drugs that is most interesting is we know in CTCL this intracellular signaling, the signaling that takes place in the cell that says divide, proliferate, keep growing, is in this pathway called the JAK-STAT pathway. And we're trying to figure out how we can better target JAK-STAT. So I think that's going to be one of the most interesting ones. We have some of these newer ones that target the immune system in specific, like the checkpoint inhibitors, which we've seen a lot. Getting back to these commercials, pembrolizumab, those kind of class of medications. And then we have a newer, exciting therapy that's still in the works, which is the CAR T cells, which is engineered cells against taking your own cells and engineering them against the cancer, which are being used in multiple different types of cancers at this time.
There's also a study looking at a molecule called KIR-DL2 that is reportedly having good results in particularly Sezary patients. And so that's in an active clinical trial now. It's not available on the market yet, but I think that's exciting as well.
Okay, so in regards to CAR T, we have done some recent videos on it that are on the Foundation's YouTube channel, if anybody wanted to take a look at those. Next question I have is, can you give some general recommendations to deal with fatigue?
I'm going to let Dr. DeSimone answer too, but I would say the one thing, fatigue is a multi-headed beast. I think fatigue absolutely can come from a cancer when you have the different cytokines or cellular kind of juices revved up. They can also come from the anxiety of having a cancer, not sleeping well. They can also come from medications and not eating well. So I think fatigue, it's very hard to pinpoint one thing and say, if I fix this, I can make fatigue better. But one thing I will say is respect the fatigue. If you have a cancer diagnosis, if you're going through a lot, take the time to take a break. Don't feel like you have to push through everything. Do what you can, but then do take that nap, and just respect the fact that you are fatigued, and there could be many different reasons for it. And then look into what your day looks like. Are you sleeping? How restful is that sleep? Are you eating a good balanced diet? Are you sharing your anxieties with your loved ones. Are you drinking plenty of fluids? These are the questions when when my patients come to me and say, I'm fatigued, that we start troubleshooting and just recognizing that fatigue is a very complicated word.
Okay, our next one is there data on using MOGA long-term in a maintenance plan if the cancer is pushed back? And if yes, what does that maintenance regimen look like in terms of frequency?
I don't believe at this point that there is published data on using MOGA in a maintenance capacity. This is kind of what I was talking about before, which is we need to start to make more concrete recommendations for how to utilize various drugs in the maintenance capacity. However, anecdotally, for patients who respond to MOGA, many providers will back off their dosing. So when you first start a patient on MOGA, it's every week for a month and then every 2 weeks. But for patients who are doing really well and tolerating the drug without any major side effects, many providers will then start to back off that dosing to maybe monthly or Q6 weeks. But being able to determine what the optimal dosing regimen is to keep that drug in your system in a way that's going to be beneficial in controlling disease, we don't know the answer to that yet. One of the things we need to look at.
Thank you. This is the last one I have for online. So if anyone wants to get any more questions in, or to the live audience, to the online audience, get your questions in. What are the other targeted blood screens besides flow cytometry to keep up with being in remission, to know if you're in remission?
I mean, in addition to flow, which again, I'm very cautious about just using that and hanging my hat on that as a remission. But in addition to flow cytometry, we also do clonality studies to look to see if these are clonal, whatever we find in the blood. But other than that,
so typically we don't do, this goes back to what's indicated. For a patient who clinically is in remission, it may not be indicated to do a screening flow cytometry. Flow cytometry is not usually utilized in a screening capacity. It's used for diagnosis, it's used for staging, and then it's used for monitoring of response to therapy. But in general, if a patient's clinical exam looks benign, perhaps you would do a complete blood count annually, which is indicated for most adults anyway, and you would get a surrogate marker with the white blood cell count and the percentage of lymphocytes that may be useful as a catch-all if you have some drift away from remission. But again, it really depends on the specifics of the case. Is this someone who's had a stem cell transplant and we're monitoring them that way? Because in that case, we might do something called chimeric studies to just make sure that you're still all donor and that you don't have a bunch of your initial immune system coming back. But in general, the guidelines and screening blood work are all based on clinical exam. So we wouldn't be doing any other additional analyses like high throughput sequencing on the blood or anything like that in a random fashion to screen for recurrent disease.
I think just to add to that, I also, when we do testing, hopefully as Dr. DeSimone is saying, if there's a positive result, we're going to act on that, right? And so if we see low-level detection in the blood, which, and you're otherwise well, and if we say, well, we're just going to watch that, all we've accomplished is increasing anxiety, right? We haven't really done anything helpful. And so that's why we're very cautious about doing these screening studies.
So when you talk about screening, beyond, like when people are staged, like at the beginning, beyond that initial, your 2B or whatever, does that serve any purpose in the long run? Like, does it matter if a person is, I'm making stuff up, okay? You're 3C, and then after, a year, 18 months of treatment, are you going to be restaged? It's an idea that I'm just not sure I'm clear about what the purpose is. In the short run, I think I understand, but I'm not sure I understand in the long run.
Initial staging is very important in terms of giving us an idea of two things. How aggressive is your disease? What stage was that disease able to achieve? and how good is your body at controlling that disease. So if you presented with a higher stage disease and then you've had 18 months of therapy in the example that you gave, and now you look great, when I do the documentation, I will say, patient with history of stage 3 disease, currently T1, N0, B0, M0, effective clinical stage 1A. But it is important to know what your maximum disease stage was because of the fact that it gives us insight into those two things. How aggressive is the clone that you have, even if it's in your history? And how good was your body without therapy at controlling that disease? Because it helps us understand how closely we need to monitor you overall. And it just helps us gauge a general idea of what your lifetime prognosis is. Again, this goes back to what I mentioned earlier. A lot of the prognostic curves that say, if you have stage 2, your life expectancy is this. They're really outdated with regard to how we use therapies now. They're much less relevant in practice. But knowing that a patient initially presented with a relative high stage of disease definitely impacts how closely I will be monitoring them clinically in the long run. So it does have relevance both acutely and in the long run.
But I think Dr. DeSimone and I have both seen patients where we expect them to do quite well based on their stage, or actually not so well, and we're always surprised. The longer we do this, we realize, that everybody's an individual. And so beyond that initial stage, we keep close track of how did you do with each therapy? How long were you responding? How did you tolerate it? Because really, your track record on how you've done is almost more telling to us than anything else.
I'm not sure if this is legal where you practice, but have you seen any benefits to the use of medical marijuana among your patients?
I don't have any experience with it. Some of my patients do use medical marijuana. I think getting back to what Lori and I were talking about, if you perceive a benefit, I think that, it's always good to tell your doctor what you're taking. Any herbal, any type of medicinal thing that you're using is important to tell your doctor. We've seen different herbals sometimes that can have drug interactions or may anecdotally, we think, cause flares of disease. So it's just important to share all that information.
Okay, our next one. How important is it for a patient and care partner to be engaged in their treatment journey? What are good questions to ask your medical team? Kind of a two-parter.
I think that it's so important to be real co-workers in this journey. I think it's important from the patient's side to really share what's going on. If the doctor says you're doing fine, right? Hang on a second, this is my symptom, this is my symptom. And it's important for the doctors, to really put their hands on you, ask you all of these symptomatology. I think that relationship is so important. And I think that's one of the reasons why Dr. DeSimone and I have always, kind of tried to do multidisciplinary clinics where we can have many providers there to work as a team. I, for example, always love to have a relative there too, and I often look to them like, is this what you think too? Because I think it's really important to triangulate that information.
One of the topics that came up in my session yesterday is something that I feel really strongly about, which is that in this disease specifically, even ahead of other malignancies, it's really important that there's great communication between patients and their provider team, between patients and their family members, because there are so many question marks to this. It's not the same as a patient who has melanoma, where everything is very clear cut. We know what your prognosis is. There's a universal treatment protocol that all doctors are going to give you, and everything is very clean. Here, everything is gray. And that creates more anxiety, it creates more confusion, and so that also creates much more importance that there is good communication both with patients and their partners and their families, but then also with patients and their partners and their families and us.
I think as a physician, it's always very important to me when I prescribe a therapy that the patient really understands why they're taking this, because that's how you get buy-in. And also, as a patient, I would not be okay with taking a treatment that I don't quite completely understand, why am I taking this? I think the other thing that Dr. DeSimone said is that I think cancer is so multifaceted, right? So I don't think it's just about your symptoms. It's about, can I actually afford this medication? Am I having problems with my co-pays? Often your physicians have people that might be able to help, or reach out to a company representative or something like that on your behalf. So I think all of that is really important to share.
All right. Well, I have a question, which this comes up often, is when is it a good time to seek a second opinion? And maybe primarily, for early stage patients that might be seen at a local dermatology practice that maybe they don't see a lot of cutaneous lymphoma, but, is that okay? Should I get a second opinion from an expert? What's your thoughts on that?
I actually feel fairly strongly about this, that, your cancer is yours. It's not your physician's, it's yours. And so anything you need to do to feel comfortable is what should be done. If you feel like you need a second opinion, even if you completely agree with your doctor, you're all good in your relationship, you just want a second opinion, that is yours to have. And your doctor should be helping you do that.
I completely agree with you. And in the situation that you highlighted, Susan, for a patient who has very early stage disease, low risk, normal life expectancy, stage 1A, but they have just been working with their community dermatologist who probably has much shorter appointment times, more patients to go through. I think it makes great sense for those patients at the beginning when they're diagnosed, even the low-risk ones, to come to a CTCL center, just because we have baked into our program adequate time to provide teaching, education, provide written materials, and to just give them kind of a more comprehensive explanation of what this problem is that most people in the community just are not, have not set up their practices to be able to offer. So I think a first stop, second opinion is useful, but then also even well into your care, if you're with a CTCL experienced provider, if you at any point feel like you just want to get another opinion, I also always encourage my patients to go do that. And never worry about hurting anyone's feelings or making a provider feel concerned about territorial stuff. We don't care about that. We just care about patients getting what they need and feeling confident. And whether it's with me or somebody else doesn't matter to me at all, as long as they're getting what they need.
Great answers. And that's why we have the treatment centers on our website so people can know where to navigate. Go ahead, Autumn.
Next question from online was, are there many CTL centers in the U.S. and where they are? So that is on our website, in patient resources on treatment centers.
Yes, and we're very fortunate to have more than we have ever had, which is great. That's a really good thing. More questions? No? So, any more questions from our audience? We have these two amazing, wonderful clinicians in front of us. I know it's been a long weekend, right? Had a lot of things. So then I will just ask, any final thoughts or words of wisdom or things you'd like to share with our audience here and those at home, from your perspectives, things on the horizon that you are excited about in the arena of cutaneous lymphomas? Yeah.
I'll say two things. First of all, those of you that are here today and those of you who are participating online are doing exactly what I would encourage my patients to do, which is seek opportunities to educate yourself, become an advocate for yourself. Again, because of the rarity of this disease and the confusing treatment protocols, it's really important that you take a personal responsibility for understanding why choices are made on your behalf and being really in tune with what you need. So great job doing that, making time to be here all weekend. And then secondarily, I think that we have a large annual meeting in the United States each year where we talk about multiple things, but this most recent one in March was about our direction as a group of providers who have dedicated our careers to this disease. And our direction is to try to pull cutaneous T-cell lymphoma into the era of precision medicine, which is the path of medical oncology and hem-onc management for many other disease processes. It's hard to get there because this disease is so different, and when you try to find genes and molecular markers, it's all over the board. But I think it would be helpful to know and encouraging to know that we are collectively as a nationwide team really trying to identify areas where we are behind as compared to other malignancies and how they're managed, and we're trying to get ourselves pushed more toward an era of precision medicine where we've got patient-specific markers that we can use to give you great information about your personal prognosis and that will help us choose therapies that are likely to be more effective in you than in others based on your personal disease profile. So great job educating yourself. We're trying to get this management of this disease up to snuff to be comparable with how we manage other diseases. And just glad you all are here.
Dr. Shenoy, anything you'd like to add?
She said it well. I would just say thank you to you. I think that having a foundation like this is so important for having a collective voice, for prioritizing what you all think is important, for really being a champion for pushing research, and actually championing us as providers too. I think that's just been wonderful.
Thank you. We have a lot of work to do, but it's very exciting. And thank you both for, I'm trying not to, always worries me to have that ear blasting thing. Thank you both for spending your Sunday morning with us, sharing your wisdom and your knowledge, answering all of our questions. Thanks to everybody in the audience who posed questions and everybody in our online. Really, it's a village, right? We're all in this together, and together we can really make a difference for everybody in this room and beyond and around the world. So thank you so much. We'll excuse you to go have the rest of your Sunday with your families.